to you. So, Dr. Kernberg is a professor emeritus of psychiatry at the Weill Cornell College of Cornell University. He is a visiting professor at the Albert Einstein College of Medicine and training and supervising analyst of the Columbia University Center for Training and Research. He is the past director of the Personality Disorders Institute at the New York Presbyterian Hospital, Westchester Division, and a past president of the International Psychoanalytic Association. He is the author of 15 books and co-author of 13 others, including Borderline Conditions and Pathological Narcissism, Severe Personality Disorders, Psychotherapeutic Strategies, Contemporary Controversies in Psychoanalytic Theory, Techniques, and their Applications, The Inseparable Nature of Love and Aggression, Psychoanalytic Education at the Crossroads, Resolution of Aggression and Recovery of Eroticism, and most recently, Hatred, Emptiness, and Hope. In this presentation, Dr. Kernberg will discuss the initial evaluation of patients for psychoanalytic treatment, with particular emphasis on their personality structure, differential diagnosis, and prognostic indicators. He shall describe the method of the structural interview developed by the Cornell Personality Disorders Institute. Dr. Kernberg will be speaking for about an hour and a half, and then we have about an hour for questions. So thank you, Dr. Kernberg, and welcome, and we look forward to your presentation.
Thank you very much for your nice introduction. I am a little overwhelmed by the number of people. I thought I was doing supervision or talking with a small group of candidates. My question is, I don't know to what extent the majority are really candidates in psychoanalytic training, and how many psychologists, psychiatrists, social workers are in the audience. Do you, Dr. Murphy, have an idea of the composition of the audience? No, you have no information. Well,
no. I didn't, it was like an overwhelming response, so that would be a good question for future.
Yeah. Well, I will address myself then to psychoanalytic candidates as the main audience, and I assume that most of you therefore have are either psychiatrists or psychologists or psychiatric social workers. There must be sprinkled a few other professions, but I would consider those as the most represented ones. And therefore, I'll assume general knowledge of psychiatric pathology, differential diagnosis, some clinical experience of all of you in terms of psychotherapeutic background. So that will be a level at which I'm planning to present what I have to say. We had planned to leave for me to talk for about an hour and a half and then raise questions. I think that's probably the best way to proceed, rather than suggesting to interrupt me at any point, because there are too many of us. So I will stick to that schedule. My main point, my main message is that to become a good psychoanalyst, one really has to have good and deep knowledge of psychiatric pathology and general knowledge of psychiatric and psychological therapies. In general, in psychoanalytic institutes, the establishment of a good comprehensive diagnosis of the patient at the beginning of treatment has been badly neglected. It is a major critique I'm making of psychoanalytic education all over the world on the basis of my experience. This has been benign neglect at best, up to a general anti-psychiatric attitude at worst, such as is prevalent, say, in French culture. To tell a psychiatrist, to tell a psychoanalyst, you really are a psychiatrist, is an insult. I may be exaggerating this a little, but the general bias is pretty strong. There is a general attitude also that at the beginning of the treatment, one should ask the least possible in order not to influence the transference. Too detailed, too careful evaluation of the patient brings about transference distortions, and we want to keep the field as clean as possible. I think that is a phony rationalization of the ignorance of diagnostic assessment, to put it very simply. If we intervene trying to clarify issue from a technical neutral position, in other words, trying to get information without valuing in a positive or negative way whatever the patient is going to tell us, the patient will realize that we are trying to find out as much as possible about him, and I'm not looking for issues to criticize or question. And if a patient is sick enough to feel that asked general question is really an attack, and the patient gets very cautious and refuses to talk, then yes, there is an early transference, a paranoid attitude that interferes with our diagnostic study, and we have to do all we can to reduce that in realistic ways. We may tell the patient, I realize it's difficult to talk so openly about yourself, but in order to be able to help you, I really need to know all that I need to know to be better able to assess your personality, your difficulties. This applies particularly to the patient's sexual life, where for conventional dominant reason, there are major difficulties in conveying information. In the most Western cultures, there's a great reluctance to talk about intimacy of sexual life, although there are some cultures in which what cannot be talked about are financial issues. In the United States, for many people, it would be easier to talk about their masturbatory fantasies than what their income is. So we have to deal with cultural difficulties in assessing various aspects of the patient's personality. So the first task we have with a potential patient is a full assessment, and you can use the general psychiatric or psychological diagnostic interview that you are familiar with from your profession. That's perfectly appropriate as long as you apply it in a full and comprehensive way. we have developed at the Personality Disorders Institute of Cornell what we call the structural interview, the method of structural interviewing, which is an enrichment of the traditional mental status examination to focus particularly strongly on personality disorders, to enrich the diagnostic study with a first segment that covers personality disorders, and really all the issues that we loosely group under neurotic symptoms and neurotic character pathology, and neurotic character pathology and personality disorders are clinically, practically overlapping concepts, although from a strict theoretical and scientific viewpoint, one has to differentiate personality as the overall totality of psychological functionings of the individual from character, which is the presence of habitual behavior patterns that differentiate individuals from each other, that take the name of personality traits in general psychology and are really character traits, character structure, character defenses within psychoanalytic understanding of psychopathology. So I will describe to you that interview in details. That's the main content of this presentation. Let me tell you that it has been very helpful and a successful introduction to the field that has permitted us to sharpen our diagnostic assessments. We have carried out empirical research to validate it. The clinical interview, the structural interview that I'm going to present to you is the clinical way of carrying it out. For research purposes, it is not precise and sharp enough. We have transformed it into an empirical instrument, the STIPO, S-T-I-P-O, structural interview for personality organization, that has been empirically validated. The reliability of it has been confirmed, and there are by now numerous empirical investigations that use it as a significant instrument of the type of personality disorder and severity of personality disorder. So the STIPO and the modification of the STIPO for adolescents, STIPO A, which is still undergoing significant research, is now widely used in empirical research on psychotherapy process and outcome. The interview starts. I'll first give you the briefest outline and then go into great detail. The interview starts out with a focus on the patient's symptoms and an effort to obtain a complete, absolutely complete symptom list at the beginning of the treatment. Physical, emotional, social, whatever the patient may have from a psychological, psychiatric viewpoint. That's the first subject of the interview. Second subject of the interview is the study of the patient's present personality functioning. And we study present personality in the main areas in which life develops, that is work and profession, love and sex, social life, and creativity. That's the second part of the interview. The third part of the interview studies the patient's identity as the most important indicator of the degree of severity of the personality disorder, and for practical purposes, the axis around which all other personality problems get organized. Fourth, we study reality testing, a very simple symptom that, however, opens the key to whether we are dealing really with a neurotic person or personality structure, or whether we may have missed an atypical psychosis or an organic brain damage. These are the, and if we find out by that key that we have missed either an organic brain damage or a psychotic disorder, then we do standard classical psychiatric evaluation for the corresponding illness. So we switch into the general, into a well carried out general psychiatric interview. If the patient's reality testing is normal and solid, then we don't need to do anything else. We have the diagnostic interview completed, and then we can go into significant aspects of the patient's history. Notice that we first study the patient's present symptoms and personality before going into the history, which runs against the tradition of psychoanalytic institutes, where very often the interest is to go into the first year of life. The patient tells us few symptoms, and then you find out what happened between 1 month of life and a year and a half. And you go on from there. And very often you have a history of family relations, but end the interview and you really have very little knowledge except the main symptoms that the patient spontaneously gives you. So this interview changes that tradition. We take the history already knowing what the present pathology is, and therefore are able to focus more sharply on issues that may be particularly relevant for this present pathology. Okay, that's the overview. Details. Patient comes in and we greet each other. I present myself. I'm Dr. Kernberg, and I ask the patient what his name. I want to find out the patient's name and age as basic data. And then I tell the patient whatever I know about him and have heard about him. Dr. So-and-so referred to you and has told me such and such. I give the patient full information in ways that he can understand and tactful enough so that we avoid his interpreting it in any way as if we were criticizing or raising questions. So the patient knows what I know about him, and I tell him, now I want to ask you a number of questions to know more about you. If I don't know anything about the patient, I tell the patient, I only know you were referred to by so-and-so, and I would like to raise a number of questions to get to know what brings you here. And then we ask the patient 4 questions in one uh, in one continuous sequence. I tell the patient, I'm interested, first of all, to know what brings you here, what brings you to the interview with me. What are the second question I ask is, and what are your general difficulties? So I'm asking what brings you here? What are your general difficulties? Then I ask, what do you expect from treatment? And finally, where are you now? So I ask the patient, I want to ask you several questions. First of all, what brings you here? Why are you coming to see me? What's the nature of your difficulties? What you expect from treatment? Where you are now. This is a mini test, as you can imagine, of the patient's capacity for attention, orientation, short-term memory, intelligence, appropriate ways of relating with us, self-awareness, having a kind of understanding what's going on and what he wants to do about it. So it's like a quick mini test, and patients may react in many different ways. The patients may tell us very directly, I have serious difficulties with my husband, and I've been told it's my own problems, and I do have periods in which I get very anxious and I don't know what about. So I have some anxiety, long-term anxiety, and I have some difficulty in dealing with the children. My main problem is really the chronic difficulties with my husband. I wish something could be done about it. That is a very sophisticated response. Another patient may tell us, oh, my mother brought me here. And so looks at us, he has given us enough of an explanation. So our task is then, and why did your mother want you to come here? What did she think, or what did she recommend to you, and how do you understand that? So we're in a completely different ballpark. So we are prepared to answer according to the level of response, and immediately get a feeling, of course, for the patient's capacity to realistically convey all this to us. You, as psychoanalytic candidates, probably will see patients who have this degree of sophistication. If not, they wouldn't be referred for analysis. We see everything from severely organic and psychotic patient to hysterical personalities and obsessive symptoms. So we are geared to very careful diagnostic studies. So for you, this will be less of a problem in general. Once the patient has given us an answer to this, we go into detail about his symptoms. And we immediately, with any specific symptom, try to make the differential diagnosis. Patient says, I feel depressed. We may ask him, what do you mean by depression? And ask the question that permit us to do a differential diagnosis between major depressive illness, bipolar illness with episode of major depression, or depressive psychosis, or whether, on the other hand, it is a characterologically based depression, chronic dysthymic reactions, neurotic depression. So we try to clarify each of the symptoms that reflect multiple degrees of severity or different type of problems. Sometimes patients come and a patient comes and says, I have a borderline personality disorder. And so we ask him, what do you mean by that? I've been told that I have a borderline personality, or you must know that. I would say, yes, I know that, but I would like to know what it is that you have that fits with that. What are the difficulties that you put under that label? Patient says, I'm paranoid. I ask him, what do you mean by that? Rather than assuming that he knows that it's an exaggerated idea of hypersensitivity and suspiciousness, etc. So we clarify each symptom and ask the patient for all, once the patient tells us his symptoms, we ask him, do you have any other symptoms? Any other symptoms or difficulty, physical, emotional, social? Patient says no, so then we ask the patient, so if you didn't have any of the symptoms that you told me so far, would you be perfectly all right? And patient may say yes, so we know we have a complete symptom list. Or the patient may say, well, who is ever free of symptoms? And we may tell him, you have a point, but is there anything in which you think you are beyond the average that everybody would have in ordinary life? So we really try to get to the limit. And that may take 10 minutes or it may take an hour. So for the initial interview, we reserve at least an hour and a half, which we see patients between 45 and 50 minutes. So it's either 90 minutes or 100 minutes interview. And we, in many cases, you can reach the diagnosis in one interview like this. In others, you need 2 or 3, not more usually than 2 or 3. These are really very difficult cases. Once we have all the symptoms we are keeping in mind, but are not yet bring it up, what the patient expects from treatment. You remember that was one of the questions. By the way, the reasons why the 4th question is, where are you now? Is that the 4 questions have a decreasing degree of structuring. First question, what brings you here? Is a highly structured question. Second question, what's the nature of your difficulties? Is already less structured. What do you expect from treatment? Less structured. Where are you now? 0 structure. Because the sicker the patient, the more this will show when the external structure is lost. So a schizophrenic patient may give us a good answer why he's here. But when we tell him, where are you now? He may let loose and we get all kinds of strange responses, so that there is a structural organization of these 4 questions. Back to the fact that we have all the symptoms. So we don't go into right now into motivation for treatment, what he expects from treatment. We tell the patient, I now would like to learn about your present life, your present activities, to get to know you as a person. And then we ask the patient systematically about his functioning at work or profession. If it's a student, of course, at school. then about love and sex, then about social life, including family structure, family relations, and finally, creativity. We ask what the patient does in his free time, whether he has any hobby, any interest, anything that he's doing for pleasure other than work to earn a living. And in each of these areas, we try to find out whether the patient is functioning normally or not, whether the patient has difficulties or not, whether the patient is able to be up to function at the level one we could expect given his age and education and gender and culture, whether he gets along well or not with other people with whom the paper is connected, and is happy and gratified with what he's doing in that area. So efficiency, appropriate level of functioning, well-being, and gratification are the main areas. We assume that a normal person would be working at the level at which he wants to in the profession he's interested in, would be happy doing that, would have an intense love relationship with a stable partner with whom there are feelings of love and a great sexual life, a good group of social acquaintances, close friends, and reasonably good relations with the family, and have some particular interest in the area of sports, culture, politics, art. So we build up in our mind at that moment when we ask the patient about his present life, how this patient would function perfectly in everything. We imagine that nice person in front of us, all the things that he would be doing well. And of course, immediately as we learn about concrete life, we learn about where this is not so. And we are alert and sensitive to all the difficulties. We find out about the difficulties by having an implicit schema in our mind of what a normal person would do. We all do that anyhow. In the structural interview, we are just expliciting, among other things, the internal attitude of the therapist. Regarding work, more specifically, we find out what the patient is doing, whether this corresponds to his background. Is he working at the right level? Is he working below his capacities? Is he severely challenged? Does he have great difficulties so he can't function? Failure in school, losing one job after another, etc. How is getting along with people with whom the patient works, with bosses and superiors, and with subordinates. How stable is the work? Does it correspond to what he really wanted to do? Is he doing what he wants to do? Does he feel that he's forced to do something he doesn't want to? What are the difficulties in doing what he wants to do? So we try to get a very good awareness whether everything has been going all right, or what serious problems there are. Typically for a patient with borderline personality organization, patient may say, well, yes, I've gone to college, I studied Indian philosophy and photography and business administration. I don't know exactly what I want to do. I'm now working as a salesperson in a department store. So something already sounds chaotic, disjointed, and we try to go into depth what was the real interest, if there are any. Is this a 30-year-old woman without any real interest in doing anything in her life, which would be a serious lack of orientation regarding work that usually goes together with identity diffusion. It is, we ask the patient whether he's earning enough for a living, whether he has financial difficulties, and to what extent the patient's financial situation is commensurate with the kind of work. If it isn't, what he's doing to improve or change it, or to what extent the patient is able in general to do any work, or sits at home and eats popcorn and watches TV, and is maintained by the parents. So we try to get very full information and already an indication of the severity of which segment is disturbed. Then we go into love and sex. We ask the patient whether the patient is involved in any intimate relationship. It depends on gender, age, culture. 17-year-old girl, we may ask, have you been dating? We ask patients, have they been in? Would ask, have you been interested in dating or not? What interests you is, have you had any romantic relationship? Are you interested? Do you know what that is? Who attracts you, men or women, boys or girls? We try to assess relatively soon whether the patient is heterosexual, homosexual, or bisexual. We ask the patient whether he or she has had a stable relationship or not. Any relationship, how long have they lasted? Why have they fallen apart? Is he or she involved in a stable relationship? Is it a good relationship? Do they love each other? Has he been in love with anybody? Does he or she understand what it is to love a person? Because a number of patients may tell you they've never understood what love is about. We ask them whether they have seen movies in which they show couples that go through unhappy stage, and then finally the couple finds together and everybody feels happy. I mean, I'm talking about an extreme now. We try to find out whether the patient has had that experience of falling in love, being in a relationship, in a stable relationship, or having never had any relationship lasting more than a few days. We ask whether the partner is in love with the patient. And we may ask the patient, how does the patient know that the partner really loves the patient? So we want to know whether there's a capacity for tenderness, for passion, for idealization, for emotional love. And we want to know whether their sexual relation is satisfactory. Are they having sexual relation or not? Has the patient ever had sexual relation? I mean, that may be perfectly normal not to have had sexual relation for a 13-year-old, but if we find a 40-year-old man who has never had any sexual relation, of course, it's a major issue. We would ask, why not? Have you been interested? Have you had opportunity? Any fear? What's the problem? And in intercourse, are patients able to get excited and have orgasm? Do they know what orgasm is, orgasm or climax? Is it, and of course, a crucial question is whether they get sexually excited and can have sex and excitement and orgasm with the same person with whom they have an emotional connection or in love with. To what extent these two things go together, or there is a split. They are able to have tender feelings toward one kind of persons and no sexual impulses, and only sexual impulses toward person toward whom they feel nothing. Patient may tell you, yes, we have a very good love relation. He has given me a new, given me a new, fantastically new iPhone. And last week he paid for a trip to a resort. So we have an excellent relationship. So I may tell the patient, so it seems you're very happy with the gifts you're getting from him. Would you be equally happy if he didn't give you gifts? And the patient says, well, you can tell that a person loves you because a person gives you gifts. And I may ask the patient, well, so you also give gifts to the person? Well, I give him my love. So you can already see that there's something problematic about the interchange. So we try to find out whether there are indications of really capacity for love, commitment, for a good relation, or whether one is fighting like cat and dog all the time in the relationship, and to what extent there are any kind of sexual inhibitions. And we'll go in great detail. If somebody says occasionally has a difficulty in erection, I go into detail whether sex lasts, whether he has a premature ejaculation, retarded ejaculation, selective impotence with one or other person. If the patient doesn't know, the patient asks you, so how long should sex last? I would tell the patient it's very variable, but usually we think that the average of sexual intercourse is somewhere between 2 and 10 minutes. Somebody who always reaches orgasm in less than 2 minutes may have a premature ejaculation, and somebody who always needs 20 minutes of active intercourse before being able to reach orgasm may have a retarded ejaculation. So in the case of women, we try to find out whether there is sexual inhibition and how severe the sexual inhibition is. The mildest one, everything is fine except that they can't reach orgasm. There is sexual desire. There is increase of desire and sexual response in sexual foreplay, more excitement with penetration. So everything is, but it stops just before orgasm. That's most frequent and in a way less mildest or less severe of sexual inhibitions. If there are all excitement stops at the moment at which there are penetration, it's more significant. If there is no sexual arousal, that's never indicates a significant inhibition. And if there is zero sexual interest, both in men and in women, then we really have obviously a very serious problem in that area. So we go into detail if there are problems. If everything seems okay from the start, then it may not be necessary to go into all the detailed difficulties, but we are prepared to do it and make a precise diagnosis. This is an area where patients may have great difficulties, but our experience, when I say our, I mean the collective experience of all our research group and institute, is the more natural these issues are for the examiner, more easy the response of the patient without inhibition. So the internal attitude, how one asks these questions and is prepared to deal with difficulties, will make a very important difference. The most severe problems in the work area are, of course, chronic incapacity for any active engagement with the world, in simple terms, and secondary gain of illness. Secondary gain of illness consists in the utilization of one's difficulties to obtain additional support from the environment. Patients with personality disorders who can't work and get supported by family or the state. There is no reason with any personality disorder why patients should not be able to work or to study. So these are just the usual rationalization of secondary gain. It is very important for those of you who work in state or city organization where you have people with very low levels of income. There's frequently the utilization of psychological or psychiatric pathology to justify inactivity, ongoing social support, secondary gain and exploitation. People who work in private practice with wealthy background, there is somebody who has a kind of a parasitic existence and has convinced a member of the family to support his or her life without having to work or to do anything. These are the most frequent cases of secondary gain, and it is important to diagnose and correct them at the beginning of the treatment, because they constitute an extraordinary resistance, both in psychoanalysis and in psychoanalytic psychotherapies, and have something to do with endless psychoanalyses of patients who earn endless support on the basis of symptoms that are used for rationalization purposes. It's one of the prognostically negative indicators for the treatment of severe personality disorders, the important overall that needs to be diagnosed. The other one is severity of antisocial functioning. We'll come back to that. Regarding sexual difficulties, the most important difficulties are the total inhibition of all sexuality and the incapacity to love, which is most pronounced usually in severe narcissistic personalities, and one of the difficult symptoms to improve, for which psychoanalysis is an excellent indicator, the incapacity for normal love. So both psychoanalysis and at least the transference-focused psychotherapy, which is a psychoanalytic psychotherapy closest to psychoanalysis permits the treatment of that. So that's more severe than chaos and sexual promiscuity that sounds very often as socially disturbing, but indicate at least the capacity of involvement with others, even if it is only in terms of sex, and the improvement in the internal world of object relation permits to normalize the sexual promiscuity. So it looks more dramatic, but it's less severe by itself. From sex and love, we go into the area of social life and creativity. We find out whether the patient has a close group of friends or not, stable friends or not, good or bad relations or difficulties, how the patient gets on with the family relations, with spouses, of course, fundamental, with children, with in-laws, with the parents of the spouse. The whole complexity of family pathology is smoked out in that process. The most important problems are excessive dependency on the family of origin, adults who are still behaving like children in the relation to their own parents, difficulty of dealing with children, very often reflecting one's own psychopathology and its projection on the interaction with children and spouses. We carefully study the nature of the relationship of the couple if there are problems. That is strangely neglected in psychoanalytic institutes, in most of them, not in Great Britain, where the Tavistock Clinic has had a very healthy influence, and not in France, the French have greater freedom of discussing all kinds of sexual difficulties, and that includes the difficulties of marital couples as well. You should be able to evaluate the nature of a marital relationship or a couple relationship by studying the three major components, which is how they get along sexually, how they get along in the arrangements of their daily lives, how they get along in terms of their value systems and harmony between their long-range objectives, ideology, thoughts. It's not important that they have the same religion, but there shouldn't be major conflicts in their belief system. We have found it very helpful to have candidates read at least the book Marital Tension by Henry Dix, which is the standard book of analysis of couple conflicts within the psychoanalytic literature. It's been the basis of many other texts, but the essence was there. After studying the relationship of friendship and family, we ask, do you have any particular interest? What do you do in your free time? What do you enjoy doing? Movies, books, friends, sports. Of course, sometimes such interests are used for defensive purposes to compensate for inhibition in other areas. Then they become particularly interesting. That completes the analysis of the present personality functioning, the second part of the interview. third part of the interview, identity. What is identity? As you know, it is the integration of the concept of the self and the corresponding integration of the concept of significant others. Under normal circumstances, the integration of identity occurs somewhere between the third and fourth year of life. When it doesn't occur and there remain severe splits between idealized and persecutory segments of experience, both regarding the concept of self and the concept of significant others, we have the syndrome of identity diffusion, the indication of borderline personality organization or severe personality disorder, severe psychopathology, where the question arises whether this is a patient still indicated for psychoanalytic treatment, or would it be preferable to do a psychoanalytic psychotherapy? Usually that's not the question that comes up with patients who have integrated concept of self, integrated concept of significant others, in other words, normal identity integration and neurotic personality organization. Usually there is a correlation between the nature of personality disorder and whether there exists identity diffusion or identity integration. Usually obsessive compulsive, depressive masochistic, and hysterical personality disorders have a neurotic personality organization, not always, but usually. In contrast to histrionic or infantile, borderline, narcissistic, paranoid, schizoid, schizotypal, hypochondriacal, and antisocial personality disorders that are all severe personality disorders with borderline personality organization and severe identity diffusion. I'm not going into details because it's not the subject of this meeting, but you should be able, on the careful evaluation of work and profession, love and sex, social life and creativity, to come across the main symptoms of the various personality disorders and already be able to make the diagnosis on that basis, combined, of course, with the observation of the interaction of the patient with you in the interview. So that a careful evaluation of all these elements will give you automatically what is the predominant personality type of the patient. And the study of identity will confirm whether it's a neurotic personality organization or a borderline personality organization, and complete the diagnosis of the personality organization of the patient. It is the most important aspect of the interview, really, and the most difficult assessment methods. We ask the patient, once we have completed the study of the various elements of personality, now I would like you to describe to me some of the most important people in your life. You have already mentioned, and we mentioned 2 or 3 people that the patient may have already mentioned and seemed to us as really important, as available all the time or much of the time to the patient. Can you tell me in a few minutes so I can get a live picture of her? Can you describe the personality of your mother so I can get a feeling what makes her different, what makes her a unique person, different from other women? How would you describe her? That requires an effort on the part of the patient. It's not easy, but under ordinary circumstances, it is possible for the patient to say, well, the most important aspect of my personality, of my mother's personality, she's all in all a very friendly and nice person, but then some things have to be done rigidly the way she wants to, and then she loses her flexibility, and either you do what she wants or you leave her alone, and that makes for difficult contact. You have to guess what it is about which she has kind of rigid views, and you can't get around it. That's one example. A patient may say, oh, I love my best friend. She's just fun. She's just fun most of the time. Sometimes she can be irritant, and there are days where I can't stand her. But when she is in good terms, it's wonderful. Yeah, she's usually a good friend. I mean, there are times where she fights with everybody and can't relate to anybody else, but she has good times, and she can tolerate me usually pretty well. This is a much less clear description, and that contains contradictory elements in it, and it can get much worse. We asked the patient to describe 2 or 3 of the most important persons, and usually, once the patient has done that, and we feel the patient has learned what he has to talk about, then and only then we ask the patient, now can you describe yourself to me, how you are as a person, what makes you different from anybody else, what's unique about yourself? So in a few minutes, tell me enough about you so I get a first feeling for you as a person. Obviously, we are asking this to a patient about whom we already have learned an enormous amount, so we can compare what the patient is saying about himself and what we have already observed, and find out to what extent the patient is able to describe himself. From normal description to sometimes pathetic confession of incapacity to do it. One of our patients told us, you know, I'm like an onion. You want to know how it's deeper, so you take off a layer, but then there's another layer, and then you take off another layer, and at the end there's nothing left. This is what I feel about myself. That was, I thought, a wonderful description of identity diffusion, the lack of integration of the concept of the self. It's difficult to assess that. It is the most difficult part of the mental status examination. The way we train our students, and that's very effective, is we ask them to do this evaluation of identity with 10 patients of hospitalized borderline patients who usually have severe identity diffusion. And we ask them to to do 10 of these interviews with their friends, because we assume that our students have mostly relatively normal people as friends, and that the chances are that their friends are mostly have normal identity integration. And it's a very effective method, because after that, they get the feeling of the difference in the descriptions. And it becomes a very reliable method. One has to remember that first you have to ask for the description of significant others, and then the self, because there's a training involved that maximizes the information about the self. Here you can differentiate here very clearly. The neurotic personality structures show up different from the severely borderline ones. And the study of identity permits you to differentiate, say, a hysterical personality disorder from an infantile or histrionic. As you know, in the DSM system, they condense the hysterical and the histrionic. I think, with all due respect, that the committees that studied the classification of personality disorders have been so influenced by politics and the professions they represent that this field has been painfully neglected over many years. The fact that the analysis of the vicissitudes of self-representation and object representation are the main components of the organization of personality and of pathology, that in psychoanalysis we have learned over many years, and in our institute we described 30 years ago, only has emerged as a reality in the alternative classification of the DSM-5. The alternative classification sees as criterion A the integration of the concept of self and the relation with significant others, and as criterion B, the differential characteristics of various personality disorders that in the DSM system still is taken from the from the myth of the 5-factor system that stems from massive factor analytic studies of the population at large, and not from the clinical study of personality disorders. Just as a little side remark about how in this area psychoanalysis has so much ahead of its time and has been ignored by this segment of the classification of both the DSM system and the ICD system, the International Classification of Mental Disorders System. Okay, back to the structural interview. I would expect that you have good, solid knowledge about the clinical characteristics of the different personality disorders. And I think as part of psychoanalytic training and the analysis of the initial evaluation of patients, there should be just a checklist on the fact that people have a really clear and sharp capacity for differential diagnosis of different type of personality disorders. Anyhow, once you have decided the patient has integrated identity or identity diffusion, you have completed your analysis and are able to make a diagnosis of the patient's personality, main symptoms and difficulties. And the only thing that remains now is reality testing. What is reality testing? Reality testing is the capacity to differentiate self from non-self, intrapsychic from external origin of stimuli, and to maintain empathy with ordinary social criteria of reality. From a psychoanalytic viewpoint, it is a capacity of a sharp differentiation between self-representations and object representations. If the patient has positive psychotic symptoms, such as hallucinations and delusions, clearly reality testing is lost. So if you have a patient with chronic hallucinations and delusions, you have to make the diagnosis, what is the psychotic condition or the psychosis implanted on an organic brain syndrome. If the patient has no hallucinations or delusion, the patient may at least have very bizarre behavior, bizarre affects, bizarre behavior, bizarre ways of thinking that are outside ordinary expectations. And even if it looks that in general the patient is behaving pretty normally, he or she may have difficulty in differentiating the ordinary perception of reality that others have, an incapacity to empathize and identify with the usual habitual social perception of a present social reality. So if the patient has hallucinations and delusions, reality testing is lost. There is a psychotic syndrome that has to be diagnosed. I'm talking about true hallucinations, not pseudo hallucinations nor illusions. I trust that you know the difference between hallucinations, pseudo hallucinations, and illusions. Illusions are false perception of real objects in the outside. Pseudo hallucinations are false perception that one recognizes as products of one's own mental activity. You see the Virgin in the corner of the room and you believe, oh, it's the Virgin Mary, she is there. You're convinced she's there. That's a hallucination, a visual hallucination. But you can look through her and you know that it's your imagination that gives you a sense that she's there. She's not really there. That's a pseudo hallucination. You hear the voice of your grandmother who died 20 years ago, and you're convinced it's the grandmother who is talking to you. That's an hallucination, an auditory. You hear her voice, well, I'm imagining that. That's a pseudo hallucination. Pseudo hallucinations you can find with severe personality disorders. They don't have that function of indicating loss of reality testing. Same with delusion. The patient, you have to differentiate obsessive ideas, overvalued ideas, and delusion. I take it all of you know what obsessive ideas are. False ideas that impose themselves. You recognize they are false ideas, but you can't stop thinking them. Overvalued ideas, false ideas impose themselves in your mind. There are times when you think this is crazy, this is my imagination. And there are other times you think, oh no, it's true. You think that the Catholic are persecuting you. Sometimes this is crazy. I know that that's totally absurd. And at other times you think, well, they know that I was a Catholic and I stopped their religion, and they are still very resentful. So it may well be that there are general instructions against me going on. So these are overvalued ideas. Overvalued ideas don't indicate loss of reality testing. Delusions do. So the patient has no hallucinations, no delusions, seems to be in general functioning well, but something in the interview with you gives you a sense there's something flaky, inappropriate, cuckoo, strange. You can't quite put your finger on it, but the patient doesn't look right. That's a good feeling for something being wrong. And reality testing is testing that very perception that you have. So at this point of the interview, having completed the study of identity, you ask yourself, has there been anything unusual, strange in this interview? And then you can tell the patient, as we were talking, I noticed such and such or such in patient's behavior or affect or way of talking or thought content. So I tell the patient, I notice you're doing that. You explain to the patient what you noticed. That seems strange to me. Can you help me clarify that? If the patient has maintained reality testing, he's able to understand what you just told him and give you an explanation that makes it less strange or inappropriate. Reality testing maintained. If the patient gets more disorganized, confused, anxious, and feels less clear what you're really talking about, you hit an area where reality testing is lost. And you can diagnose loss of reality testing and study whether there's a psychotic organic process. It is very easy to do, and has been well known in psychiatry for ages. And it always impresses me that it is not taught, but in general, that's a deficit in psychiatric teaching, that psychiatric symptomatology is not taught sufficiently well in many psychiatric programs. And that, of course, that affects the psychoanalytic candidates who come from such programs. So you have to be sure that that you are up to date in psychiatric semiology. I'll give you a few examples. A patient comes in, and during the interviews, I notice that every time the patient says something sad, he starts smiling. We have it on videotape. It's kind of strange to see. The patient says, well, and then well, I was training my daughter and she fell from bike and broke her arm. Smiling. And then he says, and this was right after the death of my mother, smiles, and so on. I mean, it was, I could almost predict it, and it had a strange quality to it. So at the end of the interview, I told the patient, you know, as we were talking, I noticed that every time you were telling me something serious or sad, you started smiling, and that seemed strange to me. Can you explain that? And this patient said, I know exactly what you mean. Whenever I have something that makes me feel sad, I have to smile. It is a problem. I should have mentioned it to you. Reality testing, perfect. Second example, a young woman comes to see me. It comes with a bunch of flowers. You are Dr. Kernberg. Here, the flowers are for you. So I thank her. I tell her I don't think there was any need to bring flowers to a doctor you were going to see the first time. And I started structural interview. And the patient had an ongoing friendly attitude, enthusiastic attitude, telling me everything as if she was telling me the happiest experience, very appropriate, describing everything, but with an attitude of joyfulness, as if this was the great opportunity of her life to give me all that information in this way. And you already have made the diagnosis, of course. And at the end of the interview, when it came to that point, I said, you know, you came to see a doctor who you had never seen before, brought me a bunch of flowers. That was unusual behavior. And then during the interview, you have been radiant, telling me all about your life, good and bad things. It didn't fit, that mood didn't fit with the many things we were talking about. Can you explain that to me? And the patient looked at me and said, oh, don't be such a sad sack. It was a hypomanic condition. It was a bipolar illness. And one more example. We have some incredible examples of loss of reality testing. I'll give you the most extreme. We had a patient who, during the interview, avoided looking me in the eyes. By the way, this was part of a research project, so that's a videotaped interview. A patient avoided looking me in the eyes and answered all my questions, gave me the information. And then at the end I said, I notice you have been avoiding looking me into the eyes all throughout the interview. Well, that seems strange to me. And the patient had great difficulty in answering. And I said, it would be very important that you dare to answer so I can get a better understanding, because something must have been going on. And she said, I was afraid that if I looked at you, we might fall in love with each other. And we might have sex. And at the end of sex, you would discover that your penis remained in my vagina and would be enraged. And it would be very dangerous for me. So I almost missed a psychotic illness. This is extreme, but milder forms of loss of reality testing may become evident at that point. If the patient, during the interview, doesn't show you anything bizarre, strange, incomprehensible, flaky, cookie, but seems to be as normal as could be, other than whatever the patient tells you about, then you have nothing to ask about. And you can assume that reality testing is perfectly appropriate. And that's the structural interview. At that point, you tell the patient that you have completed your examination, you want to know about the patient's past, and now you ask whatever seems to you relevant about the patient's past. I have nothing new to communicate than what you know anyhow, how to evaluate a patient's past history, except that we do it trying to focus on important issue and not be side-passed. Sometimes we have to talk about important issues in the patient's mind. A frequent situation. Patient comes in and I raise my 4 questions. And the patient says, I'm here because, let's say that it's a 25-year-old woman. She says, I'm here because when I was 7, I was raped by my uncle. And that has caused my illness. And the patient is about to tell me everything that happened with her uncle when she was age 7. So I tell the patient, I do understand that this is a very important aspect of your past for you, and we'll have a time to talk about it. But now I would like to concentrate on the way you're functioning now. So we acknowledge what the patient says is important, and patients come with their personal myth. They have already everything explained. So this is now the time when I tell the patient to tell me in detail. So some of the details reflect patient's personal myth, and others are objective data that we want to take. Once we have that information, we tell the patient, I can now give you my view, and I give the patient my view of the diagnosis and the treatment indication. I may do that in a separate interview, depends on how much time has gone by. So that's flexible. But at a certain point, in the same session or in the next sessions, I have lots of time to tell the patient what I think her diagnosis is and what I think the treatment I recommend. And I ask the patient what is her view about what I'm saying, and I ask her to go back to the question what she expects from treatment. What does she really want from treatment? I've just told her what I found, what I think needs to be treated. How does she react to that? And I go into great detail to analyze the real motivation of the patient, what she and to differentiate when she says, I want to learn more about myself, I want to improve my identity. I ask the patient, what do you mean by that, improving your identity? What do you mean? Or the patient says, I want to get married. I may tell the patient, what gives you a feeling that treatment will help you to get married? Is it that you feel there are internal problems that you have to resolve? Or do you think that it will give you a better chance to find the right husband? And the patient says, I don't know. I just hope I'll find the right husband. That's a very different motivation from saying something in me prevents me from getting involved in a good relationship. So we want to know what the objectives are, if the patient has any objectives or none, or whatever they are. And then, but we want the real ones, what the patient says, my mother thinks I should. I would say, okay, I understand what your mother wants, but what would you want for yourself, regardless of your mother? And once we have the motivations of the patient, we have to think, what are our motivations? What do we expect from the treatment? What do we expect to change? And there has to be at least one important objective shared by patient and us to warrant the treatment. This is a very important fundamental principle, to study the real motivations of the patient as the end of the diagnostic evaluation, compare it with our motivation for needs to be changed, and finding at least one important area where we coincide, that can be spelled out. It can be said, we agree that this is something that you want change, I think that would be changed, and that warrants treatment. I can tell the patient, you have other objectives, I think they're important, we'll explore them. And I can see other issues in which you need treatment, but we can explore those later. And patients may ask you, what else do you see? And I would tell the patient what I see as major issues that the patient hasn't seen. And the patient says, oh, I'm in disagreement with that. I said, that's perfectly all right. We are agreeing on the main issues. We are disagreeing on others. And I'm leaving that open. And this really cements the treatment and will help you in periods of negative transference when the patient is ready to drop out of treatment, and you have to remind the patient why he comes into the treatment to begin with and what still needs to be achieved. After that, there are a number of issues that have been dealt with, but you already have pre-selected patients for analysis, so much of these other issues will seem less relevant. Whether we need information from third parties, whether we need put conditions to the patient under which we are willing to do the treatment because the patient is engaged in self-defeating, dangerous self-defeating behavior that we have to stop, and which way we are stopping it. If you carry out psychoanalytic treatment with severe personality disorders, then these issues become relevant. Whether you need environmental information, whether you need some kind of environmental intervention, whether you need to spell out certain conditions, and how you will deal with certain typical crises. Let's say the patient has chronic suicidal tendencies, then you have to know how you're going to structure the treatment that controls the suicidal tendencies. If the patient has drug dependency, alcoholism, you have to decide whether you want the patient to be simultaneously in treatment by specialists in drug addictions or eating disorders, and how to structure the treatment, how to maintain contact, and what contact do you have to maintain with third parties, treatment of adolescents and children, contact with the family, under what conditions. And these are highly specialized arrangements. I don't want to go into, except that this is a time for taking care of them. If the patient shows antisocial behavior, if there's a history of antisocial behavior, any patient with antisocial behavior, you have to make in your mind the differential diagnosis of all the conditions of antisocial behavior to eliminate the possibility of treating an antisocial personality in a strict sense who has zero indication for any psychotherapeutic treatment, including psychoanalysis. So these are already complications, except that so that your knowledge about psychopathology of antisocial behavior becomes important at that point. Antisocial behavior, suicidal behavior, drug addictions and abuse, eating disorders, the protection of the treatment by adolescents and children, or when third-party payers are involved. Once all of that has been discussed and is resolved, then you can tell the patient, now I will teach you how we are going to work together. And you have already arranged your usual conditions about time and payment and when the patient will be charged and not charged and how to deal with vacations and all the rest. Let's say you have dealt with all this, everything is in place, and then you say, okay, your task will be to do what is called free association, and I'll explain it in great detail. And we explain in great detail what it is all about. In all cases, even if you analyze, if a psychoanalyst comes into treatment with you, you still explain it to him at the beginning of the treatment. There are good reasons for that. And you tell the patient, my task will be to listen attentively to everything that you're saying, and to be ready to communicate to you whatever I'm learning, which goes beyond your awareness of yourself. So you go to the limits of what you know about yourself. I will provide you with more information about what I think may be going on in you, and what may help you to understand the internal conflicts related to the difficulties for which you come to treatment, and which we have just agreed upon really is the difficulty that we both agree that we should work about. So I'll be attentive to that issue, to everything you are saying, try to help your understanding and your capacity to begin to deal more and more with the main issue for which you're coming to treatment.
Dr. Kernberg, I'm sorry to interrupt you. I just wanted to ask you how much longer you think, how much longer do you think that you would like to present? Because I'm just aware of the time.
You are asking me at the very moment where I was going to say, that's all I wanted to say.
Oh, okay.
So now is the time for raising all kinds of questions, comments, reactions.
So yes, please use the hand function, the raising hand function, and we'll ask your questions, or you can ask your questions to Dr. Kernberg. So Goran, would you like to go? And then just put your raise hand down and your mute function when you're done.
Yes, sure. Thank you very much. Good evening, everyone. And Dr. Kernberg, my name is Goran. I'm a psychiatrist and a candidate psychoanalyst. I work with war trauma, and I just have a question which is maybe tangentially related to the structural interview. I was wondering, how do you see the question of complex PTSD diagnosis, which is going to be, or which is introduced in the ICD-11, and which, according to a lot of people working in the trauma field, is going to pose a lot of differential diagnostical issues when it comes to borderline personality disorder and complex PTSD. So I was wondering, do you think that this structural interview can help us with that differential diagnosis. Thank you. And thank you for a wonderful presentation.
Thank you. Yes, I think the interview can take care of whatever the classification of the relationship between trauma, post-traumatic stress disorder, complex post-traumatic stress disorder, personality disorder. And I think that the diagnosis of complex post-traumatic disorder is problematic and has to be clarified further. I think that they are missing the diagnosis of the personality disorder of many of these patients. So they are, I'm not certain about the quality of discussions that are going on, quite frankly, but in any case, whatever the decisions are about official classification and how to classify patients, the structural interview will take care of it. In fact, I can see no other way to differentiate the complex area in which they are involved. We do have, by the way, I'm talking out of the specific experience of treating patients who have complicated psychiatric syndromes following the attack on the towers in New York City on September 11. We found out that those patients who were supposed to have extended post-traumatic conditions really had personality disorders that predated the attack on the towers and had not been sufficiently studied. So it's a complex area. In any case, the direct response to you is there should be no difficulty in using that for diagnostic purposes.
Thank you very much.
Dr. Kernberg, do you need a break at all? A 3 or 5 minute break?
No, I'm used to teaching 8 hours a day.
Okay, okay. So Andre, would you like to ask Dr. Kernberg your question?
Hello, doctor. I'm Andres, a clinical psychologist in Mexico and psychoanalyst candidate. Thank you for your wonderful lecture. My question is, how does a structural interview integrate the assessment of risk of patients with self-harm and risk of suicide or harm towards others? Thank you.
Well, as I mentioned to you, these complications are taken care of after the end of the specific interview and before the decision is made about the treatment. So we have developed specific techniques of dealing with them. When it comes to suicide, if patients are chronically suicidal, you have to decide whether they have severe depression or not. Suicidal tendencies with major depression have indication for hospitalization, psychopharmacological treatment, and supportive psychotherapy until the depression has been resolved. And then one can see what other treatment is indicated at that point. Suicidal tendencies without major depression, without bipolar illness, with major depressive symptoms, in other words, characterologically based depression, we treat as a complication of the personality disorder. We tell the patient that whenever he feels like killing himself or herself, he should feel free to discuss it in the sessions, at his regular session time. if he feels like killing himself and can't control it outside the session, he should go to a psychiatric service or an emergency room, be examined, and if necessary, be hospitalized, notify us, and the treatment will continue as soon as he's out of the hospital, or in the hospital if the therapist works in that hospital. He should not call the therapist in between the sessions, but in between the sessions, he has to assume responsibility. Either he controls it under the next session, or he goes into a hospital if he can't control it. That's his responsibility to treatment. We discuss it with the patient as a precondition for a psychoanalytic psychotherapy or psychoanalysis, but for a psychoanalytic type of approach. If the patient is not able to accept that, we would refer him to a supportive treatment with medication, but would see contraindicated a psychoanalytic approach. We recommend to the family not try to support the patient, not discuss suicide with the patient. If the patient talks with his parents and says, I'm suicidal, they should tell him to discuss it with his therapist. In other words, we eliminate secondary gain of illness by asking everybody else to stay out. Suicide from now on is a problem between the patient and us. And when this restriction is in place, we analyze the function of the suicidal behavior in terms of the developing transference in the sessions. So the combination of a firm structure of the treatment outside the session and an immediate high priority for interpretation of its meaning in the light of all we know at that point, that's the technique. Let's take parasuicidal behavior, chronic cutting. If the patient carries out superficial cuts that don't leave chronic self-cutting, that don't leave scars, we don't pay attention to it. It's not dangerous, and we just analyze its transference implication. It's seen as one more form of acting out. If it's serious enough to require medical attention, suturing, then the patient has to go to an outpatient clinic and be treated concretely for his wounds. That becomes equivalent to the suicidal patient who has to go to a psychiatric service, and we're willing to treat the patient under these conditions. If the patient has an addiction, he has to start the treatment for the addiction with whatever the specialist tells him. And that specialist, and we are in ongoing contact with the understanding, is that if the patient is not responsible to follow one part of the treatment, the total treatment will be ended. With eating disorder patients, bulimia, obesity usually don't represent emergencies. Severe anorexia, yes. More than 15% loss of body weight requires active treatment of the anorexia. Loss of 30% of body weight, hospitalization, and beginning of the treatment of the anorexia in the hospital. So these are brief examples I'm giving about conditions that we established to treat patients with these complications. It may take several sessions to get the patient realize that either he accepts that, or we will not continue seeing him. We make it clear to the patients, and make it clear to the family. And the combination of controlling behavior and interpreting its meaning simultaneously is what's usually very effective.
Thank you.
Hi, Susan. Would you like to ask your question? Susan, you're muted.
Hi, I'm Susan Snow, and I'm a candidate from Oregon. And thank you very much for this excellent presentation, Dr. Kernberg. It will influence how I approach my initial interviews for sure. I'm interested in particular about what you tell the patients once you get through the interview about free association. Just curious.
What I tell the patient about what? I'm sorry, I didn't understand.
Oh, about, you said at the end of your talk that you tell the patient that their task is to do free association, and
Yes.
you explain it in great detail, and I'm curious about what you tell them.
Oh, what I tell them about free association.
Yeah, the great details.
Yeah, okay. Well, I tell them, I'm going to ask you in each session, first I ask a patient to lie down on the couch, I'll be sitting behind him, or now that I'm seeing patients online, I will tell the patient that we'll be facing each other face to face. The conditions for analysis have changed under COVID conditions, and which is an interesting problem in itself, which we could discuss, but leaving that aside, I tell the patient, so this is the way we are going to confront each other in each session, and I will invite you to say whatever comes to your mind while you're here in session with me. That sounds easier than what it is. Normally, what comes to your mind depends on three kinds of situations. First, on your agenda, on tasks that you want to carry out. Second, on what you observe around you as you're talking with me, what's going on in your environment. Third, what comes from deeper levels of your mind in the forms of memories, wishes, fantasies, dreams, questions, images, whatever. I'm going to invite you not to have any prepared agenda or subject. You don't need to prepare yourself for the session or decide what you want to talk about. No preparation about any subject, just expect things coming up in your mind without you being able to predict what's going to come up next. Second, you will have the same consistent position here in this room regarding me being on the couch or seeing each other on the screen or whatever. So there will be a minimal of distraction from the outside. It will be similar than if you sit in an airplane and look out and are just leaving your thoughts, or even in a train, you look out and you are letting your thoughts go. And under these conditions, the deeper level that comes from your inside, from your mind, will be the main subject that we examine. And I will help you to examine that. Your task will be to try to communicate it as directly as you can without carrying out any kind of censorship, whether it seems to you important or unimportant, interesting or boring, something to be proud of or ashamed of, fearful about, or curious about. In other words, trying to be as complete, as completely direct in expressing it. And I will intervene whenever, as I told you, I feel I have something to contribute to your understanding, to your knowledge beyond, about yourself, beyond the point where you are, and of course to establish the connections with the issues that we agree upon are your main problems in the treatment. That, in a nutshell, is the explanation.
Thank you.
So there are a couple questions in the chat, Dr. Kernberg, and so we'll take one from the chat and then I'll ask Malgorza. Did I say it right? No, probably not. Okay. So Dr. Kernberg, do you consider this type of interview can be applied to children's therapy with the parents? And this is from Vera.
This interview has been adapted to be applied to children. Of course, modified in the application to children, to some extent to adolescents. It is done to the patient individually, not in the presence of the parents. But there may be an indication for joint interviews with the parents. If the parents pay the treatment and they want to know what treatment and why is it necessary, from case to case, we may decide how much do we need communication with the parents. Usually, whenever we communicate with parents, it's with parents in the presence of the patient. We try not to do anything behind the back of the patient. An important problem, of course, are patients who refuse to participate in interviews with the parents, and that we deal with according to what case is involved. In some cases, we try to resolve that to be able to see them jointly. In other cases, we let it be. That already depends on individual decision, but in individual circumstances. But in general, we try to have all the communications open to all those who are involved. If parents approach us, we tell the parents that we want to share with the patient the fact that they have approached us. So we try to keep very open all the channels of communication. In the case, of course, children with severe behavior disorders, we are responsible for the behavior of the child in our office. The patients are responsible outside our doors. So we have to keep that very clearly in mind. Who is responsible for what?
Malgorza.
I'm Gosia, and I'm a psychologist and psychotherapist and psychodynamic therapist, and I wonder how to act when I asked a patient about his significant others, because it happened to me that the patient looked at me like I am a crazy person because I'm asking to describe his mother or his father, husband, wife. and just say, oh, you know, it's a man, I like him, and that's all. And I don't really know what to do with it because no, it's not enough.
First of all, I have difficulty seeing who is asking the question. Can you see me?
Yes.
Oh, it's you who is asking the question. I wasn't aware of that. I didn't quite understand what you were asking. Can you please repeat it?
Okay, so I wonder how to act when patient doesn't know how to answer me, how to describe to me the significant others. When he looked at me like I am crazy because I'm asking about it, like it should be so obvious.
How to act when the patient cannot describe what he feels? Is that what you're asking?
Well, when the patient doesn't know how to describe significant others, mother or husband or partner.
The patient, did you say, cannot describe them?
Yes.
How to act when the patient tells me, I cannot describe my mother.
Yes.
I cannot describe my partner.
Yes.
I would ask the patient, what prevents you from describing them? I would ask the patient, what makes it so difficult? Do you have such a case? Do you have seen such a patient? And what did your patient tell you? What made it so difficult?
And it's happened that they say it's something general, like he likes reading or riding a bike, and there is nothing specific for this person.
But I didn't quite understand it. That there's something there, like what is there?
The patient told me that this husband or wife like books and riding a bike, and it's so general that I can't really imagine this person.
What happens to the patient when she rides a bike? I didn't understand that.
Oh, Dr. Kernberg, what she's saying is she asks her patient to describe their significant other. And the patient gives like generalities, not detailed information to help create a picture of who that significant other is. They might just say generalities like reading a book, or he likes to read a book, or he likes to ride a bike. And she wants to know, how to handle that.
Yeah. Thank you. I had difficulty understanding the other person, so I appreciate your doing the translation. I would ask the patient, these are activities that many other people could also do. Is there any way in which she does it that's different from other people? Or it's just she does the same thing like all other people, reading a book, riding a bicycle, and there is nothing that she does or says or feels that is any different from anybody else?
Okay, thank you.
And if the patient says, yes, she doesn't do anything different from anybody else, I would ask the patient whether she would recognize her mother if she had a mask over her face, or she would think that it's just anybody else. I would give the patient chances, but I already am deciding that clearly she's incapable of describing anything specific. And I would wonder to what extent that is extremely severe identity diffusion, to what extent it may reflect lack of normal intelligence, to much extent it may reflect the wish to prevent me from knowing anything about her. So I would start making differential diagnosis, what explains this behavior, other than the possibility of really a total incapacity to assess anybody else. I've had the experience of seeing a psychiatrist with a sexual promiscuity involved with 3 women at the same time. And I asked him to describe the 3 women, and the descriptions were like totally the same, like one egg looking the same like any other egg. A psychiatrist. And I said, the 3 women that you described seem to be exactly the same. That impresses me. And he got angry. In the next session, he brought me photographs of the 3 to convince me that they were different. I mean, you can see that identity diffusion can express itself in dramatic ways. I would think that the patient who only describes totally impersonal attitude either is reflecting, well, what I said, in the total incapacity to evaluating another person, extreme severity of identity diffusion, or mental retardation, or effort to prevent me from getting information, or perhaps more severe illness of an organic or psychotic type. I wouldn't make the decision around this item, but it would be an alarm signal that the understanding of the environment seems to be extremely severely damaged.
Dr. Kernberg, could I ask a question? How do you feel about, if we didn't do the structural interview and working with patients, would you initiate it even after treatment's begun?
You mean I'm seeing a patient and I have neglected diagnosing the patient?
And doing like the structural interview?
Yeah, well, I may have used, I'm not saying that it is structural interview or nothing. You may have used the general psychiatric interview, and your knowledge may be sophisticated enough to be able to make a good diagnosis anyhow. But if after starting the treatment, I don't know any more clearly the diagnosis, or I'm changing my mind, there are 2 possibilities. One, to try to clarify with the patient the area that now is making me feel I missed something very important. Or if even doing that, I can't clarify it, I would tell the patient, I have a diagnostic difficulty in your case, which is important for your treatment, and I would like a colleague to do an independent study of you and give me his or her view, a colleague whom I trust because of the senior expertise. So I would use a colleague if needed. Because sometimes patients may change the diagnosis. I had a dramatic case who came because of obsessive and obsessive ideas and overvalued ideas. Sometimes he felt as if he was Christ. He knew he wasn't Christ, but he couldn't kind of resist it. After several weeks of analytic treatment, he had the firm conviction that he was Jesus Christ, and clearly was psychotic, and he had a schizophrenic illness, and I had missed it, or it was in the process of decompensation. I sent him to a colleague. I told the patient that I thought he was having a psychotic illness, and I wanted him to see somebody else to make sure. And he ended up hospitalization and neuroleptic medication, and improved, but it was a kind of an impressive experience. So one has to be prepared that unusual things happen. I mentioned to you the case of this woman who thought that my penis would get stuck in her vagina. That came out of open air from nowhere. And by the way, this was a woman with a schizophrenic illness, and we have follow up several years from the treatment that she got elsewhere, and she did well and was well treated, but she certainly was not a personality disorder.
So there's a question in the chat that says, from Pedro, can this model of interview, can it be applied to primary attention system of health? I think that's primary care system of health. I'm in Chile working in a mental health unit.
Of course, it can be used in any place where one has enough time to do a diagnostic study. The problem is that some places have such a high demand, few professionals and many patients, that not enough time is taken. There are some places where patients are going from one hospital to another, and the fact that we have an electronic records and there are concrete questions that have been to be answered. So we have all the questions have to be answered, and there's no integrated picture of the patient. We need an integrated description. Sometimes only the admission notes of the hospital tell us what's really going on. After that, it's one form after another, and you can't tell who the patient is. So for psychological analysis, to have an integrated narrative that reflects our understanding is fundamental. The person who does the interview should be able to reach a conclusion of what he or she is seeing, rather than simply filling in question in a questionnaire, or else just taking verbatim. If you tape a structural interview you transcribe it verbatim without doing any analysis in your mind about what you have been finding, then it really is not a structural interview. It's the right kind of question, but the analysis had been missing in the mind of the person who's doing the questioning. we sometimes find that people whom we supervise do the right questions, ask everything, but don't put it together in their mind. They wait for us to put it together in their mind. The person who is doing it has to put it together in their mind, because only that permits to really do focused questions. You have to construct the patient in your mind as you are talking with him. That image that I gave, to imagine a normal person and then fill it in with all the problems that the patient has, that's one way to keep an integrated view of the patient while at the same time realizing what his problems are. I don't know whether what I said is clear enough.
Roland, would you like to ask Dr. Kernberg your question, please?
Yes, so I'm from Latvia, and I wanted to ask, are there any important details about the frame of the treatment that you would mention? Thank you.
When you talk about frame, what kind of things do you have in mind?
I mean, questions concerning the regularity, missed sessions, sessions due to the illness, and so on. Yeah. Yeah,
I understand. Yes, we decide what frequency, the duration of the question, what frequency of sessions, make arrangements with the patient so that he can come to these times, try to be as helpful as we can, the patient with his own time requirements, and of course with what we have as a possibility. It's a negotiation, but once we have agreed upon, then we expect the patient to come all the sessions. Patients who don't come to sessions, obviously these are resistances that have to be interpreted, but and we expect these are forms of acting out that we interpret, we expect to be resolved through interpretation. If they cannot be resolved through interpretation, then we set up the conditions under which we feel this treatment can still be carried out, give the patient the limits that we are setting, and telling him if he goes beyond these limits, the treatment will come to an end. So we are ready in every case to end the treatment if the patient is not able to carry out the conditions that we think are essential in his case. The same has to do with payment of the treatment. We have to decide what method of payment and what are the boundaries, the minimum that we expect in terms of fulfillment of the patient's responsibility, or beyond what point we decide it will be the end of the treatment. We have a general principle of second chance. Whenever the patient breaks the contract, we are willing to give him to continue the treatment, give him a second chance. If he breaks it the second time, then the treatment comes to an end. So at the beginning, we tell him the treatment can only be carried out with such conditions. The patient knows that, but he overrides one of the conditions. We tell him, you have operated against one of the conditions of the treatment, as we mentioned to you at the beginning. I am willing to give you a second chance, but if this repeats itself, then the treatment will have to stop. During the second chance, we interpret continuously that the treatment is hanging by a thread and that the patient just needs to overcome the same, to override the same thing he did before, and will be an end. So the end of the treatment is totally in his control. And we interpret what this means specifically within his transference developments. So the general strategy is control of acting out that threatens the continuation of the treatment or is dangerous to the life of the patient or the life of other people, including the therapist. We have conditions to prevent that. Give the patient a second chance. Interpret the risk that he will again break the contract and are willing to end the treatment if he does. It's an effective method done systematically. So it's not enough to put conditions, but you have to interpret what it means that the conditions have not been followed. And the temptation to again break through to test the therapist, and that testing the therapist is dangerous because objectively it may lead to the end of the treatment.
Thank you.
Roland, could you put your hand down for me, please? Thank you. There is a question in the chat again, just before we go to Gerard. And the question is about the importance of countertransference in the initial assessment of the patient, and also about the indicators of structural change in the course of treatment. Can you comment on that, Dr. Kernberg?
Yeah. About countertransference, it operates, of course, from the beginning of treatment and gives us important indication of where the patient stands in the various areas that we are discussing. It becomes important only if the countertransference is so intense that we are afraid we might not be able to control it. It is an so in extreme cases, it may be an indicator of whether we should treat a patient or not. It may be extremely negative. We may feel such a disgust, hatred, and rejection of the patient that it might be better that we not treat the patient. I've had the personal experience of two patients whom I reacted very negatively to. One was the son of the leader of the neo-Nazi party of the country in which I was working. And it was a disgusting individual. But I felt that I could see the problems and understand where he came from, and that I could tolerate it and would overcome it as I knew him more. And I did, and treated him. It was a very successful treatment. In the same country, I saw a patient came, an immigrant who had been a photographer of the Gestapo in the headquarters of the Gestapo in Vienna, the Hotel Metropole, where I lived as a child. I'm Jewish, and that was a very frightening place, the Hotel Metropole, and the people who worked. That was the Gestapo. From there on, people were sent into concentration camps and to the east. I felt I couldn't treat that individual, so I sent him to somebody else. The other possibility is of intense positive countertransference. You see a patient, a young male therapist sees a patient, a woman, and he feels, my God, this is the woman of my life. He should transfer the woman of his life to a colleague. So I think that these are precautionary ways of dealing with extremes. They should be relatively rare, but one should listen to that. One doesn't need to love one's patients. One can have negative countertransference caused by the very pathology and be able to work with that. And in analytic work, usually these intense initial reactions will change as one gets to understand where the patient comes from and identifies with the patient's issues. That would be my general attitude.
And Gerard?
Yeah, you had mentioned that when you're working online, you're face-to-face as opposed to in person when it's the couch. Can you say something about your decision to work face-to-face when you're online and what may be the advantages or disadvantages or different ways that affects how you work online face-to-face versus in person on the couch?
When I work online, I always work seeing the patient face-to-face. I think that in itself, of course, online, one is much more distant from the patient, and that's obvious. And to compensate for the lack of direct communication of affect by non-verbal means, the contact from face-to-face replaces that, because our facial expression carries a major part of our affect expression. I have found surprisingly easy and gratifying to doing analysis online. That has come as a surprise to me. We have been interchanging our experience in our group, and we all have had that surprising experience. That's much easier to do analysis online than it seemed, except that it is more fatiguing. It at the end of the day, it leaves a greater tension or sense of fatigue. So it requires an extra effort to maintain the emotional contact with the person one seen on the screen. So I've gotten used to that. That's really, and I think that for the initial evaluation of patients, it makes it much more difficult. The structural interview online is more difficult than in person. It can be done, but it's a major effort, takes more sessions and much more concentration. It becomes really difficult.
Well, we're all out of time, and I just wanted to thank all the candidates for joining us, and stay tuned because we're going to advertise some more programs for all of you to participate in. And we really want to thank you, Dr. Kernberg, for your time and the presentation. It was excellent. And thank you for all your work and for going before us and being a giant for us and giving us so much information to become better psychoanalysts. Thank you very much.
Thank you for your kind words. I appreciate them, and if I have been helpful, it gives me pleasure. I think that the diagnostic study of patients is one of the weaknesses of psychoanalytic training. So it is a pleasure to be able to communicate this to a large number of psychoanalytic candidates. Okay, so
Thank you.
we leave it here, and we hope that we all have a great weekend.
Yes, thank you.
Thank you,
Okay.
Dr. Kernberg.
Okay.
Thank you.
Bye-bye. Bye.
Bye-bye.
Bye, everyone.
Thank you very much.
Thank you.
Thank you.
Thank
Thank
you.
you very much. Thank you.
Bye-bye.
Gerard, are you going to stay on for a minute?
Yeah, I'll stay on for a minute.
Oops.
Did Dr. Kernberg?
Diana, are you here still? No? Sorry, Diana. Diana wanted us to take a minute to promote courses and supervision with Dr. Kernberg that are organized by the group Transference Focus Psychotherapy in Mexico. They're in Spanish, but we can maybe send something out, Gerard, if that's okay, to the people that attended this time.
Yeah, we'll see about that with follow-up from Dr. Kernberg as far as what he was offering. I think he has signed off, it looks like.
Yeah, he signed off, but I guess there's something coming up with Dr. Kernberg.
Okay.
In
Okay,
Mexico.
well, I guess if he's off, we can wrap it up, and you and I can just communicate separately.
Do you want to just sign everybody off? Gerard?
I would have to go through one by one, so we'll
Oh.
just end the session, and then you and I can touch base.
Okay, do you want to send me a Zoom link, or do you want me to use the one you sent me already?
Yeah, I can send you one.
Okay, thanks, Gerard.
Okay.
Okay, it was good.
Thank you.
You're welcome. Thank you for coming.